Trish. Hello, everybody else who will be listening to this later. So, today is our second live session, week 2. So, in our agenda, we have an overview of this week's material. There are a few items I want you to pay attention to, and these are being asked ongoing throughout the week in the discussion area, but there will be questions in the quiz as well as the final exam down the road. So when we talk about performance improvement, we need to pay attention to the organizational component. So what is typically in place? What is usually the structure in place to support performance improvement? There is a governing board of directors. Okay, so this is a group of people that makes decisions. They set the direction in terms of the quality and the expectations that are set by the hospital. And they have the overall responsibility and accountability for quality improvement, performance improvement. There is also a quality management board. Okay, so they are underneath the governing board of directors. See, the governing board of directors, in addition to quality aspects, they have to manage or to oversee administration, the finances, the types of services offered, and then when it goes down to quality management board, their responsibility is simply quality management. Okay, so they have a focused task just on that. So that's the difference. And then the third important structure is quality management liaison group. Okay, so they have the responsibility to disseminate information about anything that's quality related so that it actually happens. Okay, so all throughout the departments. They do trainings, they develop coordination, communication programs, all of that. And in all this process, what's the key theme is that there has to be teamwork, and usually teams are pulled together from different areas, and we call them multidisciplinary. Okay, so these are key things that you guys have to work around as you study. Remember those. Then there's the three basic functions of quality management. That's the first question being discussed this week. Clinical quality, utilization management, and risk management. The first one here is clinical quality. So we have standards that are the key aspect of clinical quality. So are we following certain standards in taking care of the patients? And how do we indicate that? If we follow the clinical practice guidelines and protocols, accreditation standards, government regulations, and licensure requirements. So, examples of clinical practice and guidelines and protocols were shared in that short video in the lecture area, but I can reiterate here. So what we're talking about is really detailed step-by-step guidelines that will guide physicians, clinicians, therapists, nurses, in taking care of the patients. And protocols have to do with um, things such as how do you take care of a pneumonia patient? Or what do you do when a stroke patient presents in the ER or a patient that just had an acute myocardial infarction? While the practice guidelines refer to things such as a newborn baby should get XYZ vaccine, or a woman at 40 years old or older should start to get a mammogram every year. Okay, so these are examples of those. Accreditation standards, they refer to anything that accrediting agency imposes on the facilities. Things such as, you need to keep your post-op infections down. You need to establish patient safety goals so that your patients are safe. They're not falling out of bed all the time, or they are not acquiring an infection at the hospital, things of that nature. They're not getting a wrong site surgery. Let's say they have something in their left arm and then all of a sudden the right arm is operated on. Okay, so those are examples of those. And then there's government regulations that started pretty much early on in the 90s with the peer review organizations. That's what PRO stands for, peer review organizations. And then they develop the healthcare quality improvement program. And down the road, they have the quality indicators such as core measures. For example, how to take care or what is expected in terms of care when a pneumonia or a stroke or acute myocardial infarction or a congestive heart failure patient presents. So there are examples, forms of these in your books. I want you to just review them just to get an idea, as visuals might help a little better. And the fourth one is licensure requirements. As you know, a facility needs to be licensed in order to operate. And in that license, there is a scope of operation. For example, if a hospital is not approved, is not licensed to offer trauma services, then they cannot provide trauma services. Okay, and that's part of the standards, because if they do and they're not really licensed and they mess something up, then there's liability involved. And they actually might do harm to the patient. Any questions on this? Okay, I'm going to move on to the second, to the utilization management. So in the meantime, if you do have a question, Trish, just feel free to type it there. So there's three basic tasks that we follow up with in utilization management. There's utilization review, case management, and discharge planning. Okay. Under utilization review, you have to make sure that there's a certain list of criteria. We call that screening criteria. And we usually don't develop that. Okay, it's not the health information management job to develop it because it's clinical in nature. However, you could end up doing that job because what it comes down to is really checking what the chart has, what the documentation says against that criteria. Okay, so the second component is when the review is done. Is it done before patient is admitted, pre-admission? Is it done while the patient is admitted, continued stay? Or is it done after the patient is discharged, which is retrospective utilization review? Okay, so in either case, what ends up happening is that somebody that's designated to perform that task, whether it's a nurse or a health information management person, and I actually know people, health information professionals that have worked in that capacity. Okay, so they look at the documentation, patient chart, and then they see, okay, what is documented there? What does the criteria say for admission? Should the patient have been admitted? Oh yeah, they seem that they fit the criteria, great. If not, if they see that the criteria is not met, it's not their job to question, that this was a bad admission or a not deserved admission. But they usually query the physician and discuss with the physician to clarify additional documentation to support the admission. Because chances are, more often than not, that the physician made the right decision, but they just did not document everything. Okay, so it comes down to documentation. The second function is case management, and this has to do with managing a patient's case from the beginning of admission all the way to making arrangements for certain levels of care. Okay, where should the patient go next? That's what this comes down to. And then when it comes to discharge planning, that is specific to, do we have a plan in place? Where will the patient be going after discharge? Will they go home? Will they go to a nursing home? Will they go to rehab? And so on. Any questions on this slide? All right. And the third one is risk management. And risk management focuses on identifying any potential areas of risk and analyze it. This is usually a team effort. There's people from different departments, and I see Wendy just joined. Welcome, Wendy. So basically, they will analyze the situation and see, okay, so we're analyzing the likelihood of our records being flooded, or what could happen, perhaps what type of damage could happen to the medical records. So when you identify a risk, you look at various things: the location of the department, how the records are stored, whether they were stored on paper or electronic, where the shelves are. Are they wood? Are they metal? Are they covered? What is the risk of theft? Maybe they're close to the window, or what's the risk of flooding if they're in the basement and it's an area that floods a lot? If it's fire. So basically, all of these things surface and are analyzed, and there is that type of analysis that says, well, we probably have low chances that our records are going to be destroyed by flood because we're on the second floor of the building, and this is not a flood zone, so we should be good. However, there might be a higher risk for fire or things like that. Okay, so once those are identified, then you come up with, or this group, this team will come up with loss prevention and reduction programs. So, okay, so we just identified that perhaps fire could be something we fear here. So what are some things in place? Maybe definitely smoke detectors or anything of that nature to make sure that that might not happen. Or if the risk is really high, what some places do is they purchase metal cabinets, and they actually have covers, and they protect the record much more from fire, and in the event that the sprinkler system is activated, they protect them from getting wet as well. Okay. Sometimes you can't prevent everything, but you work on reducing it. So there's things that you can do to reduce that risk. Okay. And the third one is, because we can't prevent everything, and sometimes things are going to get damaged, or there might be even clinical mistakes, and patients might die because of medication errors and things of that nature. There is definitely a third major activity that's dedicated to claims management. Okay, and that's reporting the issues, investigating the issues. In our case, in medical records, we protect the records because let's say that the physician made a boo-boo, and now they know there's a legal case, and they're in litigation process, and then they're probably trying to cover their error by going into the medical record and trying to document something they actually did not do. So that's what this protection refers to. Once it is known that a certain patient case, has gone to court, or perhaps there is, it's in the process, and the facility knows, it is our job to protect the records. And when I have worked in a couple of hospitals around here, they were usually locked in the medical records office, the director's office, actually. If we needed to abstract anything from them, we would ask our director, can we get the chart? We would abstract what we needed, and we returned it right back. So in the case of electronic information, there are other security measures in place such that nobody can edit anything in the record or change anything that was done in the past, but they can add new information, and that usually has it's dated and signed and timed and everything. So there is no way to backdate something. Does it make sense? And then the last thing here would be, if something is going to go through, then negotiating the settlement would be part of this process as well. Again, typically somebody with a health information management background may not end up being a risk manager unless you go for a bachelor degree and a master degree, and you kind of gear yourself to work in that direction. It is possible, but it is not a typical job that you would get right off the bat with your associate degree. Okay. A couple more things that I want to highlight here is patient advocacy and sentinel events. Okay, patient advocacy refers to making patients aware of what is happening. sometimes even if there is a near miss event, and the types of events, sentinel events, are described in your lecture. Okay, so you can refer to those. But a near miss event means that a patient almost was given the wrong medication, but luckily they did not. Okay, so that would be a near miss. Even such cases, are reported because the idea is not to really penalize the nurse or whoever had that error happened, but is to make sure that we are identifying potential pitfalls and come up with better processes to improve them. That's the idea of that. Or a patient perhaps um, is not fully educated health wise. They may not understand everything that's going on, and well, then something maybe did not go right during the surgery. They need to be informed, and they need to, the family sometimes, gets the information as well. So that's all patient advocacy. Okay. Any questions on these? No? Okay. So these are the types of problems you're going to see in your quiz, and that are, really the focus of week 2. So I'm going to stop the PowerPoint for now, and I'm going to go straight into the course shell. I'm going to share my screen, and I'm going to close this because we already saw that. So here's the course shell. I am now in the media gallery area. Here's media gallery. Okay. Have you guys used media gallery until now? Okay, if not, please do. I am trying to encourage you. I think I've included that in my prior messages to everybody. You could sort by alphabetical or by most recent. You could change this to maybe a detailed view like this, and it makes it easier maybe to scroll and see. All right, so what do we have? There were a bunch of videos that pertained to week 1. The practice Excel assignment was there, part 1 and part 2. Now for week 2, there is a video that's less than 10 minutes, week 2, and it shows you the difference between census, inpatient service days, average daily inpatient census. Okay, so these are all very important pieces that you need to know for now and the final exam. So rather than repeating myself now in this live lecture, I'm going to leave that content for you to look at, as you go to this. All you have to do is click there, click play, and it starts playing. Okay? So I'm going to stop it because, it is there already. Another area is the exercises area. For week 2, I posted a number of exercises with solution. So again, there's more examples here on how to calculate patient census, daily census. You have service days, that you have hospital occupancy. For example, hospital occupancy is going to be one of your problems in your quiz. I mean, it might be. It is there. It depends on who gets it because the pool is larger, and some people might get this, some people might get another type of problem. But really, all you have to do here to solve a percentage of occupancy problem is just go through this and try to understand, what the problem, how the problem is solved. And right here you have, the way the calculations are done. There is also more problems in the lesson area, because I'm not sure if everybody is really taking advantage of all the resources we have put together. So I feel that we need to explain that a little bit. So you can view the answers here. Okay, so this is the problem. You can try to solve it, but then definitely you can view the answer and try to understand it. If you don't understand it, just ask. Okay, so here's another one, and again, the solution is right there. Now, I'm going to go in the discussion area and show you where I posted the recording for calculating length of stay. So you would click on this link, and then I have a recording similar to the one I'm doing now that shows you how you can calculate the length of stay. And I can guarantee you in your quiz there will be a problem that asks you to calculate length of stay. By the way, length of stay is how long a patient stayed in the hospital. Okay, so you just give it a minute and you can scroll, like this and see how I actually showed you different tricks on how to calculate length of stay. Okay, I'm stopping it now. But have you seen this resource yet? Like I said, there will be a length of stay for sure. Okay. Yes, no. Okay. I'm going to focus on just a couple problems for now, unless you have other questions. So there are some that are already there, so I will not repeat those. But I am going to solve one that goes over the total bed count days. Total bed count days. Okay, so this is the one I'm going to work on. Can you see my screen? It's a Word document. I'm just typing on it. Okay, tell me, you can type in the chat box yes for, if you understand, if you see it. So right here we have a problem like this. Let's say a hospital had 120 beds from January to, let's say, June. Okay, then from July to December, they applied to increase the number of beds, and it actually went up to 135 beds. Okay, so you are asked to calculate the total bed count day. What is the total bed count day? The total bed count day refers to how many beds were available during that time period. Okay, so I don't see any other questions. All right, so that's really what it means. How many beds were available during this entire time? So we have a full year. Now, one little note, you might think how many days are in February, to calculate the entire year. Typically go with 28. I mean, there are years like this one, 2016, when February has 29 days. But if you're not told that, just go with 28, okay? So from January to June and then July to December, your formula sheet says that the total bed count day is equal to the number of beds times the number of days. Number of beds times number of days. The trick is finding the number of days, okay? I'm going to change this to this. Okay, so we know the number of beds is 120. Now, times what? Times the number of days. Now, how many days, for what time period did we have 120 beds? From January to June. So January has 31 days, February has 28, March has 31, April has 30, May has 31, and June has 30 days. Right? Does that make sense? Stop me if I'm moving too fast. All right? So during this time period, if you add up all the 31 and the 28 and all of that, it ends up being 181. Okay, so then all you have to do is pull your calculator function, not notepad, but the calculator. So you have 120 plus, it's 120 times 181, and that gives us 21,720 beds, bed count days. And this is from January to June only. Now we have the other part. We had 135 beds from July to December, right? So we're starting our counting again. July 31 days, August 31 days, September 31, October 30, and then December 31, and that's it. So this will give us, so we have 6 months, July, August, September, October, November, December, and it's 135 times 186. That's what the sum of these days is, 186 days. Okay, these are days, and these are days as well. Okay, and then pull up your calculator again, 135 times 186, and check your numbers. Sometimes you might make mistakes because, like me right now, I didn't type exactly what I needed to. 186. So this is 25,110. Okay, bed count days. So these are from July to December. My question is for the entire year. How do I do? What do I do now? I just really add up these two numbers. Okay, so this one, I'm highlighting it, and this one. So I have one already here, the 25,110. I'm going to add 21,720, and that gives me 46,830. Okay, so 46, let me write it down before I forget. So how did I find this? 21,720 plus 25,110. So this is my ultimate answer. Okay, it is bed count days for the entire year. Do you understand this type of problem now? Because this one is not, I believe, in that video. All right. So another one that is not in the exercises that you see there is bed turnover rate. Okay, so what does this mean? So basically, in a hospital, you have beds. How often is one bed used? That's the idea of this. So one patient is discharged, another one is coming in. So the more we use a bed, meaning it's not vacant, the more we get use out of it. So a hospital is interested in having a high numbers there. So this one is not a percentage. Let me clarify, because most of the numbers we work with usually are percentages, but bed turnover rate is not a percentage. So let's look at an example. So let's say that XYZ hospital has 100 beds. I'm just going to pull some easy numbers here. And then let's say that we're working with the second quarter, which is what? It is from April to June, right? This is the second quarter. And then they had, let's say, had 2,000, let's say, Medicare patients. Okay, so let's say this is our problem. Now, these were discharged during this period. Okay, another piece of information you're going to have is the inpatient service days, which were explained earlier. So let's say they had 10,000 inpatient service days. So let me add here, make it complete. Also, they had this many inpatient service days. All right. So with this information, what is the bed turnover rate? Bed turnover rate. And here, all right. So now let's work with it. What does our formula say? Our direct formula says that the bed turnover rate is equal to the number of discharges, and that includes death, okay? That's divided, and that's for a period of time, right? And that's divided by the average bed count day, okay? So that's the formula. So how do you apply it? Okay, so bed turnover rate is equal to, what is the number of discharges here? And we know we have a certain period from April to June, right? So it is 20,000. Actually, I said 20,000 earlier. I apologize. Here. So it is 20,000. All right? So during this period of time, what was the number of beds they had? 100 beds. That was the number of beds they had on average every day, right? Okay. Actually, this is too big. I apologize again. This was 2,000 after all, okay? Because it seemed a little too big. Usually the bed turnover rate does not end up being that big. Okay, so the bed turnover rate in this case would be 20. And that's where you leave it. That's the end of your problem. So let me recap here one more time. So what you're given is a hospital with a number of beds. You have a certain period of time, in this case a quarter. Then you're also given the number of patients discharged. You're also given the inpatient service days. And you're asked to calculate the bed turnover rate. You look at your formula sheet, which is in your RHIT formula right here. Okay, everybody has seen this, I'm hoping. Okay, bed turnover rate, you see, there are two. You use the one that's easier, that you can, this one right here is number of discharges for a period divided by the average bed count during the period. And that's what we used. We ended up not using the inpatient service days. We didn't have to. So not every number that is given needs to be used. Pay attention to your formula, pay attention to what you're being asked, and just pull the information you need. In this case, we had 2,000 Medicare patient discharges, and there was nothing specified that the deaths were not part of it. So we're just going to assume that is it, discharges, and they include deaths, all right? So don't make assumptions without any other logical basis or other explanation. And then your average number of beds is 100, and you end up with 20. So with this, with all the resources that you have in your course shell that I just reviewed with you, you should have full coverage of the content for the quiz. What I'm going to do from now until Sunday, I'm going to keep posting new problems and new questions that should prepare you for your quiz and in general for this course to meet the course objectives. Do you have any questions or any problems you would like me to solve in addition to these? Go back to, I'm going to stop sharing this and me go back to my original document. Okay, if there are no other questions, that's where we had left it last time. So really, there is nothing else I have planned here for today. I do want to answer any questions, though. That's the whole purpose of this. All right, then I will stop recording, and then I will end this session. I hope it was helpful, and let me know if there are other questions down the road throughout the week.